Bowman of SI Bone. Wanted to take this opportunity to thank Dr. Lockstadt for presenting on low back pain and SI joint dysfunction today. Before we get started, a few housekeeping items. We appreciate your engagement in the discussion and invite you to submit your questions for Dr. Lockstadt to answer at the end of the presentation. To submit a question, expand the control panel on the right side of your screen and type your inquiries directly into the questions field. We will try to address all comments as time permits. If your question is not addressed at the end, there will be a follow-up email sent out with Dr. Lockstadt's contact information. Thank you, and without further ado, Dr. Lockstadt, you may begin.
Hello, everyone. I'm Dr. Lockstadt. I'm here at Bluegrass Orthopaedics in Lexington, Kentucky. We have several locations in town, but if you're coming to the back clinic, it's the one in the Hamburg Clinic. I'm glad that you joined us today. I'm going to talk a little bit about disorders of the back and the missing piece, the piece that causes back pain, and you go have an MRI done and it's normal and you're hurting and you can't figure out why you're hurting, and the doctor can't figure out, he tells you he can't do anything for you. If that's you, this may be your talk. We'll give you a little disclaimer here first. I do some research for the SI Bone Company. I had a research grant from them. I don't get any funding from them at this time. I have no ownership in the company. And the reason I like this product is because I've done over 700 of these surgeries, and they do really well. I'm very happy with this procedure. We'll talk to you a little bit about back pain. Back pain is ubiquitous. Everyone gets it in their lifetime. Everyone is going to be down for it for a while. And I'll talk to you about the most common back pain that I see, and it's what we call the SI joint. The SI joint stands for Sacroiliac joint, and where that's coming from, if we look at the picture on the right, this is the tailbone up and down here. That's where the backbone connects to the hip bone. So where the backbone connects to the hip bone, that's the SI joint. You know, it's very expensive to take care of back pain. You know, you can go to work with a headache, you can go to work with a sore shoulder, you can go to work with a elbow pain and foot pain, and you can limp around, but with back pain, you can't work, okay? So it's very extremely costly problem for the nation. Secondly, oftentimes surgery may not work because there's so many things that can cause the same back pain. You may see a ruptured disc on the MRI study and then have surgery done on the ruptured disc and you're still hurting. Like, what's going on here? There's a ruptured disc, we did the surgery, you should get better, but you're not better. So there's just too many things that cause the exact same pain in your back. And well, the one I'm going to touch at today is the SI joint, because that one is always overlooked. The back is broken down into three different areas. The cervical spine is the neck. Cervical means neck. 7 bones in the neck. Thoracic spine, 12 bones, 12 discs. The lumbar spine is the lower part of the back. That's where everybody looks. They look at your disc, and if your back is hurting, it has to be a disc problem. Well, not necessarily. The last problem is the sacrum, and where the backbone connects to the hip bone, called the sacroiliac joint. So backbone, hip bone. Where do you hurt? In the hip, where the backbone connects to the hip bone, right in the back here. The disc acts for cushions in the back. When you get older, your discs all collapsed out. You don't have a cushion. There's millions and millions of people without discs whose discs are collapsed and they're not hurting. Just because you don't have a disc, it doesn't mean that's the cause of your pain. There could be other causes of pain. So where is the sacroiliac joint? So here you'll see the skeleton. You look straight ahead. These are your hip bones where your belt fits around. And the top of the hip bone is the pelvic bone. The pelvic bone connects to the backbone on this bone called the sacrum. Okay. So on the back, if you look at the back view, that's the sacrum, and that's your pelvic bones. So the song is true. You know, the pain is where the backbone connects to the hip bone. The backbone to the hip bone is connected by really, really tight ligaments. They hold it tight. And the theory is that these ligaments are so strong, it is impossible that anyone can have hip pain. We just don't believe that. Well, let me tell you something. The ligaments are strong, but in women, when they have a baby, those ligaments soften up to let the baby out, and then they tighten up again. Now, sometimes they don't tighten up, and that's why oftentimes you hear of women after childbirth, they sometimes have this back pain that's back where their hip is. And that's why women have this condition far more commonly than men do, all right? The problem could be in the front of the joint, as seen here, or in the back of the joint, it can be either side. And the nerves, so there's nerves that go to the front of the joint, and there's nerves that come around and go to the back of the joint. So depending where the pain is, you'll get a different type of pain pattern. So it's a very, very complex problem. How much SI joint pain is? It's got to be at least 25% in my practice. Every fourth patient that I see has this type of pain. They have the lower back pain at nighttime. They just can't get comfortable. They can't lay on their side. And the reason for that is if you're laying on your side, this is the backbone. The backbone puts all the stress through the lower bones through the SI joint. So when you're lifting, when you're pulling all that stress has to go through between the pelvic and the backbone. When you're sitting, between the pelvis and the backbone. If you have a car accident, you'll say, well, how can this happen with a car accident? Well, you've got your legs straightened out. The force is going forward. It puts a shear force through the SI joints. Con one falling. You land directly on your buttocks. When you're landing on the buttocks, you're landing on your pelvic bone. That force is transmitted into the backbone through the SI joint. And so there are many, many causes for this pain. So where do you feel the pain? Right here, and this is your back, and it's just off to the side. And so these people who will classically be walking around holding their back by the hip. If it gets really severe, the pain can even run down the back of the thigh and even to your shin, usually on the outside of the shin, sometimes in the back. And then sometimes it goes into the groin area in the front. So if you're the type of person who's sitting in a car for a long time and their back starts hurting and they have this deep, deep ache in the thigh and the knee is aching and everything aches and you just can't get comfortable, this is probably SI joint pain. So, and then in the first few steps when you get up, it hurts severely. It's unbearable. And then as you start walking, it gets a little bit better. And if you walk too much, it gets worse again. And so this is classic SI joint pain. In the morning, getting out of bed it hurts unbearable. The patients tell me it's killing me. Well, it might not be killing them, but it sure hurts. Okay, and it feels like the leg isn't going to hold them up, and they can't sleep on that side, so they have to sleep on the other side. Now, some patients are very unlucky. They have it on both sides, so they just can't get comfortable. They're absolutely miserable. I've been through this. This is classic. See, this patient has it on their right side. They can't sit because when they sit, it puts all the pressure on the pelvic bone. The pelvic bone transmits all that energy to the backbone, and that's where the pain is. So the pain tends to be in the hips, runs down into the thigh, sometimes into the groin. Occasionally, it feels like they describe that their shin is going to explode. They feel like a really tight band on their shin. Have pain going up and down stairs, and it's very stiff for them. So this is it. Pain is usually not dead center, but just off to the side, okay? And it's in this whole area, and it can sometimes radiate across the whole back. So how do we figure this out? Well, the first thing we'll do is we'll lay you on your side and put you on the pelvis. And I'll push on your pelvis and twist it and move it around and see if it causes your pain. If that causes your pain, that's pretty sure where it's coming from. The next thing I'll do, I'll put you on an X-ray machine. So this is the X-ray machine. There's the fluoroscopy screen. And we'll numb up your skin so it doesn't hurt. And then put a needle into the joint. And that'll hurt for about 3 seconds, literally like 1, 2, 3. Okay, and we're looking for 2 things. If I put the needle in there and it reproduces your pain, it tells us that's where it's coming from. The second thing that we're going to do is put some local anesthetic in there. If the local anesthetic relieves the pain within 60 seconds, your pain is coming from the SI joint. In fact, the patients get off the X-ray machine and they say, my pain's gone. I can't believe it. And at the same time, we'll put some cortisone in because oftentimes cortisone will heal it so the pain can go away for a long, long time. So we're doing two things for that, okay? We're trying to diagnose where it's coming from, and we're trying to diagnose, we're trying to also put medication in to make it heal. So it's very important that when you go see a doctor, that they look at your back. If they just look at your MRI and they say there's nothing there, that just really means they're looking for an operation for something that they can operate on. The MRI often doesn't show pictures, they'll show pain. The MRI is just a picture of your back and doesn't show pain. The best way to do this is the doctor has to stand you up and beat on your back or push on it to find where it hurts. So when the doctor pushes in the middle of the back, it may not hurt. He'll ask you, does this hurt? Does this one hurt? You'll say no, but then when he comes over to the side where the backbone is connected to the hip bone, the SI joint, he'll find your pain. And if your pain is there, that's SI joint pain. Now, if the pain is down lower, that's usually sciatic pain. That's different. That's a different type of problem. Sometimes you can have both, but we try to just have the one, all right? So we're looking to make sure the pain's not coming from the back, the pain's coming from the SI joint, and possibly from the hip joint itself. If you look at if you can see the little dimple in your back, if the pain is at that little dimple, you have SI joint pain. If the pain's down deep in the cheek of your butt, that usually means there's something irritating the sciatic nerve. That could be a disc or spinal stenosis. But if it's right where that dimple is, where that little knuckle bone is in your back, that's your SI joint. So here's some of the tests that we may do. Okay, so here we're cutting your body in half. So this is your backbone, this is your pelvic bone, and there's the SI joint here. So the SI joint, if it opens up too much, it can cause pain. If you push up and down on the pelvic bone, it causes some shear with that, okay? Then we'll do the test. We'll put your leg and your knee together and twist. This tends to open up the back. And if any of these maneuvers produce some of your pain, it's very likely that this is coming from your SI joint. So that's how we'll know. And the accuracy of this, if you have 3 out of 5 of these tests, is greater than 90% accurate. And this is free. You don't have to spend any money for this. The doctor will do this, okay? I talked a little bit about the injection. Okay, so here's the backbone. This is the sit-down bone. So when you're sitting, that's your bone. And when you sit down, all the stress gets transferred through that joint. So when we numb up the joint and put the local anesthetic in, if it relieves your pain instantly, it has to be coming from there. It cannot be coming from anywhere else. So how much pain do we think we should get better? It should be much more than 50%. You know, most people say it's just 50%, but in my experience, if you get 80 to 90% pain relief from the local anesthetic, the problem is in your sacroiliac joint. The good news is, if you have this treated with surgery, let's say the injections didn't work, therapy and exercises haven't worked, you still have miserable, you've been painful for 6 months now and just can't get better. You have the injection, and within 5 minutes, your pain is almost all gone. If you have surgery, your surgery will feel as good as that injection, okay? So if the injection relieves your pain temporarily or permanently, the surgery will work exactly the same. Let's say the injection only relieved 30% of your pain. So if you had the surgery, you would only get 30% better. I probably wouldn't have surgery or an operation that would only make me 30% better. So the injection does two things. It tells you where the pain's coming from, and it tells you how much better you should expect to get should you need surgery. A lot of the patients, when they come into my office, they can't walk very well, they can't sit, they can't stand. And then after the injection, they'll go home and they can do almost anything they want to do. The injections are so good if they give them long-term relief. If it's only short-term relief, it tells them that still that they had the problem and the surgery should work. Treatment, do the common sense things first. If you're having this SI joint pain, a rest a day or two is okay. Movement is always good for the spine. Not moving is bad. Arthritis pills, these are reasonable, like ibuprofen, meloxicam, Celebrex, naproxen. I would try those for a week or so. If they haven't worked in a week, they're not going to work in a month. Okay, so try those. And then just take them as you need them. There's this thing called the sacroiliac joint belt. All this is a real big wide belt, and it compresses the pelvis together. And it works, but the problem with that is it's very uncomfortable. You can't wear this real tight belt around your waist all day. So it's an option for you for short-term treatment. Therapy, if you go to therapy, they'll do some exercises for you. I talked to you already about the injection. The injection is a really, really good option. Now, somebody will tell me, well, can we burn the nerve? Sometimes, okay, because the joint is both in the back, but the front of the joint is inside your stomach. There's nerves both on the front and on the back of the joint. We can burn the nerves on the back of the joint, but there's no way to get to the nerves in the front. We'd have to go through your bowels, and let's face it, we're not going to cut you open to burn the nerve in the front of your hip. That's just not an option. So my experience with burning the nerve works less than 30% of the time. So what are your options now? Well, it's very self-apparent. You're either going to just live with it like you have been, and a lot of people have had this pain for years and they're functioning with it. They've learned how to live with it. You're going to do the injections that we talked about. You're going to modify your lifestyle or surgery, all right? I like this operation because for me, it's an operation I can do very efficiently. We can do it with a small incision measuring no more than 1 inch long. There's very little bleeding. The infection rate is almost zero. The chance of damaging a nerve is very, very low. Now, what the surgery involves is if this is your backbone, and here's a pelvic bone, the problem is that the joint's painful, and when the joint moves, it grinds and causes pain. So we have to stabilize the joint. To stabilize the joint, we'll drill 3 tiny little holes in the joint and then put 3 pins in the joint. I'm going to show you a video of this in a little while. Okay, it's a really neat little operation. The pins that we put in there have a rough surface on them, like sandpaper, and little tiny pores. And these pores are specially designed that when they touch bone, they're designed that they're the right porosity, so that bone will want to grow into that and heal into that. And so what that does is we put the pins in the joint, the bone heals into the joint, and that stabilizes the joint. The surgery is less than an hour. And we don't have to do large cuts with this because we do this with X-ray control. The next thing I like about the design, it's a triangular design. It's not a round design because when you put the pin in, with it being triangular, the 2 bones can't rotate. So it's a very clever design what this company has done. Briefly what we do, so the joint, we can see where the joint is. We'll bring an X-ray machine in, and while you're asleep, I would never do this with you live, you wouldn't like this. We'll make a tiny cut and put a pin in through the muscle, And with X-ray control, put the pin across the joint. Then we'll put a tube over the pin, and through the tube, we'll drill a hole into the bones, and then insert the pins, okay? This tube protects all the muscles so they don't get damaged in surgery. When you pull out the tube, the muscles drop back together. We sew you back up. If you go to recovery room, you'll have a waterproof bandage. You'll be on a walker for several weeks to allow this to heal. And you'll get a waterproof bandage so you can shower. You can clean yourself. You can feel like a human again. My experience has been that with this surgery, the patients wake up in recovery room, their hip pain is gone. They'll tell you right then and there. They'll tell you that the operation hurts, but the hip pain is no longer there. And with this triangular design, the bones can't rotate. With the rough surface, the bones heal very, very quickly where the bone grows into the pin, so it fuses it together. All right, I want to show you this little study we did. We here at Bluegrass Orthopaedics were involved with this study. We do a lot of studies here at Bluegrass Orthopaedics, but this is one of my favorite ones because SI joint pain was very poorly treated, and we were frustrated with SI joint pain because there wasn't a good treatment. And we were looking for how to improve in this pain pattern. When we did the surgery, if you look at this graph, okay, these are the patients on this side before their surgery, okay? Their pain was rated 9 out of 10, okay? Within 3 weeks, the pain had decreased to an average of 3 out of 10. And as you continued out for 5 years, the pain continued to improve. Okay, so it's a very, very good procedure. The reason that that it still hurt quite a bit at the 2-week mark is the surgery hurts. All operations hurt for a few weeks, and then once the surgery pain goes away, it's much, much better. So patients by the 6-month mark are essentially normal. The average improvement is 91%. In our study, it was about 94% here at Bluegrass Orthopaedics. So we're very happy with this procedure. Also with this study, we had, just to make it easier for you, I'm going to round it off to about 150 patients. 100 patients had surgery, and 50 did not. 50 patients that did not have surgery were compared to the ones who had surgery. Clearly, the ones that did, so here are the ones that had surgery. See how quickly they got better? And then the other 50 did not have surgery, okay? And they didn't get better. But we gave those 50 patients a chance to go ahead and have the surgery, okay? We allowed them to have it. Of the 50, 39 said, okay, we're going to go ahead and have the other surgery. The other 10 patients decide not to have surgery for whatever reason. And of those 39, look at, they all too got better, just like the ones who were the original. So this is a very good study. It shows that this is not good luck. The study is not fixed. You know, you're not saying that, oh, you just pick patients who wanted to get better. Well, so this was randomized. The patients could not pick if they were going to be surgical or non-surgical, and so this worked out very well. Now this has been published in 2016. Okay, so this information is going to be 5 years old this year. It's out there. The insurance carriers tried to deny, saying, "Oh no, this doesn't work." Well, it's been out there for all this time, and it does work. We like to have patients who've been hurting for at least 6 months. All other treatments have failed, and within that category works really well. A couple things. Let's do young people. I have done a few very young people have done their surgeries, especially in females. I'm not crazy about doing it, but I will, because if their pain's so disabling that they can't work, they can't take care of their children, they can't participate in family events, this surgery works. The problem in young women is that if you fuse the pelvis together, they may be at risk of needing a C-section for labor and delivery if they're going to have more children. Fortunately, this tends to happen more in the third decade of life, and third and fourth decade of life. So most people by that time have had their children. Risk of the surgery, I find very little risk if it's done properly. There is some risk involved with the surgery because we're doing the surgery with x-rays. We're doing it with tiny, tiny cuts. And so we're not actually cutting you open to look for the SI joint. So that sometimes if the x-rays are not clear, it may be difficult to get the pin in properly, but fortunately that is extremely rare. It's less than, in our hands, it's less than 0.2%. So it's a very rare thing. Now, if that happens, we'd have to correct it and take care of it, but that's very rare. So if you have low back pain, it's been present for more than six months, you're having the extreme difficulty with sitting, standing, getting in and out of a chair, driving a vehicle, sleeping at nighttime, this may be your problem. Especially if you have the MRI, you've already seen somebody. They told you, hey, there's no pinched nerve here. There's nothing that I can do for you. And then you'll say, well, there has to be a pinched nerve. You know, my back is hurting, my leg hurts. What's causing this? And the typical response, well, it's not your disc, so we can't help you. If that is, I think it's time to look into the SI joint as the source of your pain. While I have you here on camera, I've got a backbone here looking from the back. I have a backbone looking from the front. So where the backbone connects to the pelvic bone or the hip bone, that's the SI joint. So this is the sit-down bone. So when you're sitting down, that pressure goes there, comes through here, transfers up through the pelvic to the SI joint. So when you're bending back and forth, all that stress has to come through the SI joint. So that's why when you're getting in and out of the chair, the joint has to rotate. When you get out of bed or when you lay on it at nighttime, you're putting your pressure on there. And so I hope this will clarify it for you.